So before we get started, I wanted to say that the Eliminate Hepatitis C San Diego initiative is a public-private partnership to eliminate hepatitis C by 2030. The process started in 2018 when it was approved by the San Diego County Board of Supervisors, with the board asking the county to come back with a plan of action. That plan took 12 months of community stakeholder input. It was approved by the Board of Supervisors in 2019, and then we came back again with an implementation plan that was approved. And in 2021, the County of San Diego approved funding for a convener organization to help convene the process. And the Liver Coalition of San Diego serves as the convener. And today's meeting is really about bringing the community together to give an update. And so thank you for being here. Before we kind of go off with the agenda, let me do some introductions of folks in the room, and then we'll have folks in Zoom do introductions in the chat. So we can start this way. Come around the room.
Salvador Tapia, behavioral health manager for community health. Nice to be there. And George Scolari, a healthcare consultant and formerly with a medical care plan for 30 years.
Tamara Kohler, I'm the CEO of the Regional Task Force on Homelessness, where the continuum of care to address homelessness in the San Diego region.
And I'm Sonia Tucker, the Vice President of Population Health for Suckow.
Carla Quesada Torres, HIV Community Liaison with Gilead Sciences.
Dr. Paul Hedgie, I'm CEO of San Diego County Medical Society.
Sue Olivier, and I'm with Liver Coalition of San Diego.
Aisha Kazem and Liver Coalition of San Diego.
Great. And we've got in the room who will be monitoring the chat is Aisha. So if you've got questions that you can't hear things and you want something that you would like us to talk about or with one of the presenters, just put it in the chat and Aisha will bring it to the attention of the speaker. And with that, let's go ahead and get started. Our elimination efforts. We thought the best way to do that was start with kind of a regional approach. And I just love starting with San Francisco. The reason being is I really feel like San Francisco led the way when it comes to elimination. When they did their plan in San Diego, we reached out to our Director of Health and Human Services and said, San Francisco has this plan. We need a plan. What are we going to do with the plan? And although we had to get past the Getting to Zero launch for HIV plan, and then we had to get past hepatitis C outbreak, we did get our HepC initiative started, but San Francisco really led the way. So starting us off with our regional updates is Jordan.
Thank you so much, Scott, for the introduction. All right, can folks see my screen all right?
Yes.
Okay, fabulous. So thank you again for having us today. I'm going to share NHEP-CSF's HCV elimination milestones and future opportunities, sort of looking back at the last 12 months and then looking forward for the next year. I'm very excited to share those with you all today. So just briefly, sort of bird's eye view of what is NHEP-CSF. You heard a little bit from Scott there. So we are an HCV elimination initiative that launched in 2016. We are based in San Francisco and include over 38 organizations and about 150 individuals. On the right side of the screen here, you see a graphic that relays our structure. We are a collective impact initiative. So we use that framework to focus on 5 tenets to really inform the work that we do and how we do it. That's using a common agenda, common progress measures, mutually reinforcing activities, continuous communication. That's particularly critical to do this sort of cross-cutting, asset-based work, and then backbone support. So I'm part of the backbone. My colleague Joanne Keck, who's also on the call, is part of our backbone with a number of other colleagues. And we really kind of run kind of the air traffic control to sort of support strategic implementation of initiative-based priorities and ensure that we have the right resources and containers to do the work in our HCV elimination initiative. Briefly, hepatitis C in San Francisco. This is based on our most recent prevalence update, prevalence estimates from 2019 data. So we think there's about the seropositivity rate across the city is about 22,500. That's our estimate. And we think that there's about 11,600 active untreated HCV cases in the city of San Francisco. 9 in 10 cases we believe are attributable to folks who have a history of injecting drugs, who currently identify as active injection drug users. And that population really just represents about 3% of overall population in San Francisco. So folks who inject drugs disproportionately bear the burden of active untreated HCV in the city. Similarly, trans women of low socioeconomic status in San Francisco bear more than 15 times the burden of untreated HCV than should be expected given their population size. And then looking at baby boomers, we estimate about 27% of active untreated HCV cases are attributable to that population. They comprise only about 20% of the overall population. So again, disproportionately bearing burden. So we really want to highlight these here because and all of our work in NHEP-CSF, we really try to prioritize support for the communities that are most impacted by HCV. So this is not to say we're not working in other domains, but we're really focused on reducing morbidity and addressing risk in communities that have higher susceptibility, particularly related to and driven by structural inequities in care. So looking back, really focusing on this presentation at our key activities and milestones from the last 12 months, those prevalence estimates that I shared on the previous slide, those were part of an important update that was published in +1 in this past year, carried out by some of our partners at Vicente Consulting. As folks who work in this field know, HCV data is really critically important to driving our interventions and making sure we're doing work most effectively for folks who, again, are disproportionately bearing the burden of poor outcomes and risk in HCV, related to HCV. We also completed a needs assessment of HCV knowledge and treatment in the San Francisco County Jail. So this was a really important project. It was commissioned by our Community Research and Data Stewardship Groups, which is one of our work groups in NHEP-CSF, comprised of our partners at the Health Department in San Francisco, community public health researchers, and other academic researchers who really felt like this was a really important piece of the puzzle that we needed more information about. And that was carried out by our partners at Vicente Consulting in partnership with our local jail health services team. We also finalized a community-led strategic planning process. So it really does take a village. Again, our collective impact initiative really centers the voices of, seeks to center the voices of folks with lived experience and folks from a number of different communities. So this was about a 9 to 12 month process. It was really fun. It took a lot of time, but we really believe that the strategic plan that we developed for 2023 through 2025 is all that much stronger because of the number of voices and the time that we put into this effort. Also key activity this year was we launched a perinatal HCV working group, something we're going to seek to continue to build upon in the coming year. And then NHEP-CSF provided a small amount of funding to revitalize an HCV intervention program, which is the UCSF Deliver Caravan, really innovative, focused on mobile community-based treatment. So testing, treatment using telehealth. They have a portable fiber scan on the van. So very exciting. They're doing tremendous work bringing that care to residential hotels in the city. This is a slide from our strategic plan. So this really focuses, I'll just highlight a couple of pieces here in terms of where we're going. So some of our objectives for the next year, we really want to focus on boosting the number of HCV antibody testings that are performed, HCV antibody tests that are done in the community. Those numbers have dropped related to the pandemic, and they haven't quite rebounded to the level that we would like to see. And we also know that based on the 2030 WHO elimination targets, we actually need to continue to boost community-based antibody testing and maintain those high rates to achieve those goals. In terms of HCV treatment, we really want to focus on increasing the number of low threshold treatment opportunities in the city. So this really means, and I'll talk about this on our next slide, for bringing care to the places that are trusted, where folks are already being seen in community, particularly communities that are disproportionately impacted by HCV. And then we also want to increase the number of treatment starts for folks who are incarcerated related to our needs assessment report that we conducted. And then in terms of data, always sort of the important piece here, we really want to, in San Francisco, we've got about 75% of community antibody tests are paired with a confirmatory testing. We understand some of the barriers to receiving that confirmatory testing, and we're working with our partners at the Health Department to strategize about opportunities to boost that confirmatory testing rate. And then when it becomes available, we're really excited about the work that's been done by our partners at the local and the state health department on HCV RNA testing. We're really looking to leverage that data to inform our local elimination strategies once it's available. And then briefly just talking about sort of how we might do this work and some of our broader strategies for this coming year and the coming really 2 years related to our strategic plan. Again, we really want to focus on expanding low threshold treatment, and we want to do that in non-traditional venues where vulnerable populations are most likely to receive care. So that's syringe service programs, residential hotels, shelters, and other spaces, including MAT programs and other opiate substitution programs across the city. A key priority for NHEP-CSF is to increase HCV testing in treatment in 3 focus areas. And the areas we identified for the next 3 years in our strategic plan focus on geographic, population, and systems generated inequities in access to care. So this relates to a particular neighborhood in San Francisco where we've reported the second highest rates of new HCV cases, but we know that there's a dearth of services. And that's a community that's a historically Black community in San Francisco. We really want to focus on increased population support for transgender women and address systems generated inequities in jail health services. So for folks who have been recently incarcerated or who are currently incarcerated, so we can boost access to care across those 3 domains. And we really want to, I'll say briefly, just build upon the success of our Community Navigator program. So this is a program that began in 2018. We train folks with lived experience or who are from impacted communities to provide training and outreach in the communities. We provide a small amount of funding to 4 different community-based organizations. We train the navigators, and then those navigators are embedded in 6-month cycles at those organizations. We're about to start our 7th cycle this summer. We're very excited, and we're increasingly taking a syndemics approach to this work. So for instance, this past year, our navigators were trained and they carried out a community needs assessment related to an innovative overdose prevention strategy. And we did that in conjunction with the local health department. And then looking forward, their community navigators will be working on policy advocacy and capacity building related to storytelling, media framing, and other sort of policy and state policy advocacy work. And this is in response to what our navigators said they'd like more of and where they kind of really want to flex their skills and continue to give to their communities. So I will stop there, try to stay on time for you all. I'd be very happy to speak with anyone who has questions about our initiative. This is just a bit of a teaser, and I can also drop the link to our strategic plan in the chat. But thanks very much for the opportunity today, and I'm happy to take any questions.
Thank you so much. I think for context, let's talk a little bit. So as we go through them, each presentation, the size and scope of the organization is very different. So each community, the lead organization, the backbone organization is different. So can you share how your organization's budget and staff and size? I think you're an organization like that. I think LA, we're going to hear, is a community task force that probably doesn't have a grant. Backbone organization in San Diego has a grant to provide kind of coordination services. So we've got full-fledged organizations. So can you talk about what your structure looks like as an organization to do all that you do?
Absolutely. So we use a collective impact framework in part to really leverage the expertise of a wide number of stakeholders. And that includes, as I showed, four different work groups, a central coordinating committee, and we have 2 official staff, so that includes myself and my colleague Joanne Kay, who's our program coordinator and co-director of our Community Navigator program. And then we also get backbone support, so we work with Consenti Consulting to provide strategic backbone support. That includes meeting facilitation, support with writing, support with sort of strategic, other sort of strategy and development of key elimination priorities. They do drive a lot of sort of the epidemiologic work that we do adjacent to the health department. So I would say the health department, again, we're sort of public-private, similarly a community-based organization. Our partners at the local health department in San Francisco are essential to the way that we do this work. And then we really do draw from a lot of folks across our different work groups. So again, we only have 2 full-time staff, but we have a lot of folks that give a tremendous amount. But we really try to make those asks strategically with respect to how many different plates folks are spinning. And then again, we use an executive advisory committee that might be sort of hepatologists, other sort of transplant docs, folks who work at our local Medi-Cal health plan to really sort of provide sort of other key pieces of data and strategy and issue spotting in the community. But we try to be very thoughtful about the asks that we make of folks and really leverage that to inform our initiative priorities.
Excellent. Thanks, Jordan. Appreciate it. Next, we'll go to Los Angeles, and representing the Los Angeles Hepatitis C Task Force is Brian Risley, and he's the co-chair of the task force, and he also works for APLA Health, which is an FQHC, and he's their manager of HIV HepC Health. So welcome, Brian.
Thank you. Good afternoon. If I could share my screen, please, then. Just as a preface, I want to talk a little bit about the HepC Task Force for Los Angeles County. We are a consortium of public health, federally qualified health centers, community health workers, and other nonprofits involved in HIV and HepC elimination. We have been a task force for 20 years, so we're in our 20th year. We have an annual summit, and our annual HepC Summit Los Angeles is going to be December 5th of this year, and we'll be sending out flyers about that. We also yearly engage in what we call C retreats, and so we're going out to hospitals, we're going out to clinics, we're going out to drug treatment facilities to provide HepC education and awareness. And we also are involved in advocacy efforts. But currently, we're focused on working with LA County Public Health for us, an elimination plan, but what they're calling an action plan. And I'll explain that. The county's approach is rooted in the fact that viral hepatitis in LA County is underfunded relative to the burden of disease. And LA County Public Health receives approximately $1 million for all of viral hepatitis from CDC and California Department of Public Health. By comparison, HIV programs receive almost $100 million. So with the benefit of a CDC grant that LA County Department of Public Health, the viral hepatitis unit has, we have this new action plan, and to maximize effectiveness with limited resources, public health with the HepC task force has adopted the following principles for ongoing and organizing local viral hepatitis elimination efforts. That includes a micro-elimination approach, that viral hepatitis is a cross-cutting disease, voluntary contributions from stakeholders. And so these principles led us to frame the current action plan as opposed to an elimination or strategic plan. Elimination is unlikely with the current public health resources available for viral hepatitis. A strategic plan implies a top-down approach where public health departments achieve the national hepatitis plan targets by adapting that plan to the local context. So in the absence of funding, local health departments have limited ability to direct influence progress towards the national targets. Therefore, the grassroots approach seeks to bring together stakeholders who are motivated to voluntarily take on some aspect of viral hepatitis elimination based on what is feasible within their organizations. And let me jump into this. This is just the registry. In LA County, 100,000 residents are living with HCV. 50% remain undiagnosed. The prevalence of diagnosed HCV increases with age. Highest in baby boomer cohort, although we see that changing with opioid use in adults who are 18 to 30. Prevalence could reflect testing recommendations and practices. I'm going to go to the next slide and jump into our strategy and approach. So LA County Public Health funding, as I mentioned, is about $1 million. And HIV funding is 100 million. As I mentioned, 100,000 persons are living with hepatitis C, and 50,000 persons are living with HIV. So how can public health be most effective with limited resources? I mentioned the micro-elimination approach. So focus on high prevalence settings, unaddressed burden, disconnected from the health system. Viral hepatitis is cross-cutting. Risk factors intersect with substance use disorder, syndemic diseases, diseases common and foreign-born. Rely on voluntary contributions from stakeholders, limited public health funding to support direct implementation. In looking at the national strategic plan, we're focused on mainly 1, 2, and 4. So prevent new viral hepatitis infections, improve viral hepatitis related health outcomes of people with viral hepatitis, and improve viral hepatitis surveillance and data usage. So goal 1, prevent new viral hepatitis infections. This is through pharmacy partnerships with large retail pharmacy chains to provide a list of locations with Hep A and B vaccines. The county formerly had clinics that were open to provide these, but those hours and those clinics have pretty much vanished now. Large retail pharmacy chains will access opportunities to recommend or offer the Hep A and B vaccines, and filling prescriptions for HepC, indirect acting antiviral therapy. Also hepatitis B vaccine for adults age 18 to 59, presenting for other routine immunizations. Also prevent new viral hepatitis infections, integrate viral hepatitis education. So collaborate with other public health programs to assess opportunities for integrating viral hepatitis information into educational materials used for STIs, HIV, TB, and substance use treatment programs, and develop educational materials to train community health workers on HepC to prepare them for navigating clients to clinics that provide HepC care. Also under prevent new viral hepatitis infections, we are promoting viral hepatitis awareness. So while we do that as a HepC task force, there is in development a countywide awareness campaign called NHEPLA, and it will include activities, observance of Viral Hepatitis Month, which just passed in May 2023, organize health fair and social events where HepC, Hep B education and screenings are available, leverage social media platforms to spread awareness around viral hepatitis prevention, and then develop a LA County viral hepatitis website with content to support community partners. That would include toolkits and a resource guide. The HepC task force has produced and published a LA County HepC resource guide for many years, and we update that. We are happy to have Department of Public Health assisting us with that to broaden its scope and increase the listings that we currently have. And also under prevent new viral hepatitis infections, partnering with FQHCs and other community clinics. So engage FQHC leadership to identify opportunities to integrate viral hepatitis education and vaccination into primary care, Medi-Cal managed care plans to provide a list of pharmacies contracted to provide vaccinations. Goal 2, improve viral hepatitis related outcomes for people with viral hepatitis. So establish FQHC Viral Hepatitis Workgroup to identify opportunities to integrate viral hepatitis into primary care, including implementing Hep B HCV screening according to California law, and the national recommendations implementing universal adult HPV vaccination, establishing or expanding capacity for HCV treatment, and serving as a technical assistance platform. As I mentioned before, county wants to develop a HCV toolkit for providers that will include a directory of providers, clinics that offer HCV treatment for Medi-Cal beneficiaries, list specialty pharmacies that dispense HCV's direct acting agents, and list of organizations that offer community health workers to support HCV education and patient navigation service to clinics that treat HepC. And so educational resources on HCV treatment include Project ECHO, UCSF, HCV Warm Line, and links to AASLD and IDSA HCV treatment guidelines. And I mentioned Medi-Cal managed care plans provide a list of CBOs contracted to provide community health worker services, and LA County Public Health will assist with operationalizing use of the community health worker benefit by including the list of CBOs that provide community health worker services available for community partners who need support for navigating clients to HCV care, developing a standard provider recommendation for community health worker services that CBOs can use to support Medi-Cal reimbursement for providing the initial linkage to care services. And then in concert with our annual HepC Summit, LA County Public Health wants to conduct a viral hepatitis 360 summit utilizing a design thinking framework to understand barriers and identify potential solutions for increasing linkage to care for justice, involve clients, support syringe service programs, and developing a plan for incorporating viral hepatitis care into their workflow. So happy to answer any questions.
If people have questions, go ahead and put them in the chat, and then you put that one. And that was great. And I know that we participated in the summit. We had a number of San Diegans go up to that, and great.
Good. Thank you, everybody.
Nice. Okay, so I'll give an update in San Diego, and it's interesting when we started this. It's bringing people together that don't often come together. And I was joking that Paul, who's in our room today, and with the Medical Society and Terrault with housing, with the homeless task force, and then many of you in the room with health plans and FQHCs. Often we've been going to your tables and your boardrooms. So it's nice when you convene around our table, the hepatitis C table. So that's nice. This is our plan, and where's right there. Our 9 recommendations, which really came through our initial planning, just as a reminder, and I won't go through all of them here, but everything we do on the implementation plan, we've got lots of strategies and tactics that all fall underneath these 9 overarching goals. Of course, our goal is to decrease the incidence and then the mortalities. We'll talk about it in surveillance. We did our second benchmarking with UCSD and Dr. Martin, who was in the room, and did publish the first one. We did our burden estimate. That was a published document, but when we did a benchmarking report, so we could take a look at how we allocate scarce county dollars and what interventions would help us reach these. The results was preliminary. We might reach goal 1, but we may not reach goal 2 if we did everything. So they're looking at all the different data sets that we have available. So when we go through, there's some overarching milestones, and then we'll go through the committees. When we took a look at the committees, we aligned the 9 overarching recommendations, and then we assigned them to each committee. And then the task force as a whole has 2 of those recommendations that they do. Really participating in a coordinated way in statewide advocacy is really important. We do that through the end epidemics. That means showing up. It means going to San Diego, but as bills work their way through, being able to have relationships with your local officials and show up and they get your community, and then having partners who they serve on committees with, whether it be health or corporations, really makes a world of difference. And then having doctors who take time from the clinic and show up, and doctors that will bring the white coat with them because they know that matters to elected officials, that really makes a difference. So we've done that not by ourselves, but through coordinated efforts with end epidemics and many of the partners that are in the room today. The Liver Coalition developed the liver resources, but really trying to find our way through how do you find a doctor that's going to treat someone? And how do you not get this false number? I call this referral. And so you got this hard to reach patient, they can't get into resources. And we have 211, and we're trying to eventually get this with 211, which is our local provider. And that's as soon as they have a contract where that will expand their scope, that's where this will kind of be housed. But why wait? Current resources, we could get this started now. So we reached out working with our partners from industry, and we said, like, how many doctors are treating? And they said, probably about 70, 50 to 70. There's not like thousands in San Diego. And so we put it out there, and the doctors self-selected so that the risk burden liability is on them. They said, I adhere that I treat this and my license is current. And then we check some things, but then it's listed. And we are actually using it. I got a call just the other day from someone that was exiting the prison system, had Medi-Cal, and could not find a provider. Perfect example. Yeah. And I asked him how he found this, and it was from the internet. So search engine optimization is the way to go for the future. Not printed brochures necessarily. So our awareness and prevention committee. So we've hosted several liver roundtables for allied medical professionals, just continuing to bring knowledge to the community. Now, we're not doing this just through the initiative. So this initiative doesn't have a staff or a body. What we're trying to do is bring the partners together. So we brought together our industry partners who are doing education. We worked with our local partners like Scripps Health or UCSD, and they're doing CMO programs. And then we took a look at what other educational programs that are going on who have on their agenda something like men's health and sexual health. And so it's like, oh, that's interesting. Let's reach out to their presenter and see if they're going to talk about risk factors for HIV and HepC. And then can they include that in their talk? And sure enough, they said that they would. So we can do things like that to create awareness. Then we did the site visits and listening sessions for the Harm Reduction Coalition. And I wanted to just say that as far as one of the things, the big picture is the laundry list of things that you do, you can really get lost in the weeds. And Lori, who helped us with the slide, you said the viewing on your end wasn't very good. But Lori is great at really getting into how do you create lasting change, right? And if you want lasting change here, you've got to get into how policies are written. And she works for the county of San Diego, and she oversees a portfolio of contracts. And those contracts are scope of work. And whoever gets that contract is responsible for delivery. And they're mostly in the HIV area. And so she's been, as contracts come up, and say, where can we include hepatitis C elimination work in their scope of contract? That creates lasting focus. And when this convener role is gone, we have created institutional change. And so that's kind of really what we're trying to figure out is how does it go beyond just a convener role, but how can we create lasting change? And the Harm Reduction Coalition is a perfect example of that. It's one of Lori's programs. But when we started, the ban on new syringe exchange programs would not, a new program would not have happened. But because that was lifted, the county was able to issue the contract, other funding was secured. The Harm Reduction Coalition in San Diego exists now. That was one of the key, it was one of our key barriers to reach elimination is you had to have this type of program. That program now exists, that ban was lifted. And so we continue to work with them and support the great things that they do. And we actually did a ride along going to one of the encampment areas in our community and really listening to what they do every day, which is to build relationships and plant seeds. So that would, and then to share that with decision makers. And then we took that and the day of action up in Sacramento, myself and Tara and her team shared that with legislators. And it looks as though that there'll be some funding allocation in the tight funding year for harm reduction services. Linkage and testing committee. Engaging with many providers. What's interesting is providers naturally do this. So, you know, Sonia's with St. Institute Health Centers. I know we've got a lot of people from different FQHCs. They do testing, you know, but what they're not necessarily doing is all coming to us and saying, hey, we're doing hepatitis C testing. Letty from Family Health Centers is actually in the committee. She's great at saying, hey, we have a page on our website and we promote a standalone testing opportunity. So then we can put that on our HepC page as like a, you know, go here, go there. 2-in-1 then could promote that and say, here's like a one house of all the resources that are happening in the community. So people don't have to fight the way through a system because the system is created a one page of books do. But we don't have all those relationships yet. We're getting there. Even though San Diego is small, is finding the right person within the FQHC that does the testing, has the authority to schedule the testing, has a relationship with their webmaster that can get it posted on their website, and does community outreach. And in some FQHCs, it's the same person, and others, it's multiple. It takes a lot. So we've had some success with that. So that's what that pertains to. Building up this. And that's really the building, the engage with health center partners in Southern California. That is the really the association for the FQHCs. And we'll talk about with them also for the testing committee, and we can go there as well. Yeah. Yeah, the treatment. If I go here. So when we take a look at the treatment committees, every health center is in a different place. We heard from one community health center is we have nowhere. We've all been treated or we don't have any clients that have HepC. And that health center has since merged with another one. And so they have probably a different mindset. In fact, I know they do. And so when we take a look at down, how do we know that's true? So we have some models of health centers that look really good. And so we want to take those that are doing a good job. So we have the chief medical officer from one, La Maestra, that came and he's the chair of the CMO committee at Health Center Partners. And he shared with his peers, here's how we run our electronic health record report. And that was based on Family Health Centers example. And we say, here's everyone that's been tested. Here's everyone that we know has been treated. And here's those that haven't. And how do we find them? And that's what they start with. That's the standard. And not everyone's there yet. We're trying to dig down deep. And we've started those conversations. We're not done, but that's what that pertains to. It's ongoing. And then we published an article working with Dr. Gish, Dr. Schwartz, Dr. Dunford on the call. And with Paul's help, thank you, from San Diego Physician. But we took the opportunity to not make just about HepC. About HepC, but Dr. Schwartz said, hey, let's not forget about children. With children, screening and pregnant mothers, and Dr. Dunford, who worked for a large medical substance use treatment center, said, and what's the role from the treatment provider? So he added that perspective. So it was important that we really flesh out the different communities and take advantage of that. So that was listed as an accomplishment. And then we went up to the AASLD Viral Hepatitis Summit in Los Angeles. They did both the summit and a kind of a convening, and Dr. Ramers presented, Dr. Martin presented up there on border health, hepatitis C, outside of the border, and just good to be included on those things. The surveillance committee, we are continuing to get to where we want to go. We have a lot of numbers. The county has a lot of numbers. We could share those, but what we're trying to get to is how do we know that our investments, counting investments in dollars, that the only one that has any money, right now, for federal dollars, we leverage, are going to make a difference. And so Dr. Wooten, our public health officer, said, how do we know? And so we commissioned a report, working with Dr. Martin at UCSD, who did our benchmarking original report. And they've been looking at all these data sets. Most of them, well, I don't want to speak beyond my knowledge set, but data sets are available from either the HIV community or different sections of the population. And based on how they responded to intervention, they can model out, if we did this, this would be the indication. If we did this would be the outcome. And so we'll be able to show if we can reach our goals, and that will help the county allocate scarce dollars and help us as advocates to say, we can do it if you do this. And here's the numbers that show it. And then the county continues to just get to a point where we can have a clear number, where we're not there yet. But not that we're in a bad place. It's just that we're not in a place where Dr. Tweeten wants us to be, but she's moving in that direction. The task force, the key thing that we're going to hear from Dr. Terrault, we are having conversations, we're expanding the circle. People are talking about hepatitis C, not as much as we want, but the fact is we've had a lot of competition. During COVID, this initiative could have died. It could have been pushed on the back burner. We kept it percolating. We kept it on the stove. This last number of years with reproductive rights and safe haven, a lot of other health issues have come to the forefront. And once again, we could have been pushed to the side. We were vying for hours of key leaders' times. And when they come to our meeting, we have the chief medical officer for the county of San Diego in our meeting for an hour. That's a huge amount of time. And so the fact that we've been able to keep that investment of their time, that's a win. So that's really what I want to say about this slide. We've just got a couple left. And our future is really, what did we know? What do we know now that we didn't know before? CalAIM. Who thought about that? So, and we have a lot of plans here. Glad to hear it's out. And we have a lot of plans on the phone because Medi-Cal and enhanced care management and care coordination is really going to be a huge opportunity for the plans and how you care for our patients, honestly. And not just HepC patients, those with HIV, high blood pressure, diabetes, but we want to make sure HepC patients don't get forgotten because it's easy to forget. Unless we're here, then don't forget us. So that's why we're now talking about taking our goals, our activities, and our tactics and doing kind of this crosswalk to the CalAIM plan and say, how can our things align with yours? Educate key decision makers. Well, our key decision makers now align with CalAIM. It's all about, because there's money attached to it, right? Why fight for scarce resources and the things that are going to be covered by Medi-Cal? Let's make sure that those things align and then focus on those things that don't. So that's really where our focus is going to be for this next year, is making sure that we align what we can with CalAIM. And that, and it's mine, and I apologize for going so late. The next thing we'll do is Rachel, and thanks.
So is this meeting supposed to end at 1? We have eight minutes.
I know. Yeah, you'll be last. You'll wrap us up.
Okay, sure. I'll try to be snappy. Okay, hi everyone. My name is Rachel McLean. I also go by Ray. My pronouns are she or anything respectful. And thanks for having me today. So I'm just going to talk very briefly about a syndemic approach to ending the epidemics. Can you all see my slides?
Yep.
Okay, so in whatever year it was, last year, I think, we developed an integrated viral hepatitis strategic HIV, hepatitis C, and sexually transmitted infection strategic plan for California. And instead of focusing on kind of the diseases, we really decided to focus on the social determinants of health that are really driving these syndemics. I really liked what Jordan, excuse me, said about system-generated inequities in access to care. I wrote that down. I thought that was a really nice framing, and that's kind of similar to how we're trying to frame our work. So the 6 social determinants of health are racial equity, housing first, health access, mental health and substance use, economic justice, and stigma. So I'm going to share just one example of what we're doing in each of these areas. There are many more, but in the interest of time, I thought I would just do one. So in terms of racial equity, for example, we're using racial disparities data to identify priority populations for our STI and hepatitis C grants that we give out to local health jurisdictions. We have $5 million in ongoing funding for hepatitis C that we give out to 22 local health jurisdictions, and they in turn fund community-based organizations locally. And San Diego, San Francisco, and Los Angeles are all included among those. In terms of housing, advocates work to get the authorizing statute for those funds modified to make shelter an allowable expense. So if if a jurisdiction wanted to pay for someone to be in a motel, for example, they could. It's not really enough funding to pay for housing for people during HepC treatment, but it's nice to just have the language in there. We're also really promoting awareness about CalAIM, which Scott mentioned. In terms of health access, we're promoting a number of initiatives, some of which are tied to CalAIM around justice-involved people and promoting HepC treatment in jails. And as Brian from LA mentioned, we're promoting Assembly Bill 781, which requires primary care facilities to test their patients for Hep B and Hep C. And we also have a request for funding applications pending that will support integrated HIV, Hep C, and syphilis testing in emergency departments, which we're very excited about, because EDs are often the only source of care for people who have been systemically excluded from healthcare. In terms of mental health and substance use, we're very excited that Department of Healthcare Services issued regulations requiring methadone clinics, also known as licensed narcotic treatment programs, to offer testing for HIV, Hep C, and syphilis. And as of July 1 of 2023, they're going to be getting an increased reimbursement rate for that, which has been a sticking point. So we're hoping that that will help increase uptake of these new requirements. We're also promoting the use of community health workers, which in CalAIM are now a covered billable provider, which is a potential game changer, and promoting inclusive language, including collecting better sexual orientation and gender identity, as well as granular race ethnicity data. There's a million more examples, but we are just very excited about the work that we're doing. In terms of next steps, we are going to be disseminating a detailed blueprint that local health jurisdictions and CMOs can adapt to your local work. It's in the approval process right now, excuse me, and it was developed through about 30 town halls across California, where we got input from healthcare providers, people with lived experience, and CBOs about how they saw this work potentially playing itself out locally. So we would really encourage everyone to frame your work around social determinants of health and syndemics. And once the blueprint is released, we'll be happy to share it, and you can see how it probably already intersects with the work that you're doing. So that's my contact information, and I'm happy to answer any questions. Thanks so much.
The questions in the chat. And I know that Dr. Terrault said that she might jump back on. And Brian, you were on the call that we just had. Or actually, Brian, NVHR, you were on that call too, right? I think you're on. I can't. It's different when you're in the room and then in the room. In the Zoom room.
Hi, this is Norah. I'm back. I just
good. Oh, excellent.
Did I time it okay? Sorry.
It's actually perfect. And I just Dr. Terrault is not only amazing doctor providing medicine in Los Angeles, so she's a Californian, but she's also the national president of the Association for the Study of Liver Disease. And so she's here because they have really just taken on so much for elimination and so much for setting the standards of care. So Dr. Terrault, we wanted to go. Thank you so much.
No, thanks for highlighting that. And I am going to put on my ASLD hat here. Thanks. I think many have already participated in various activities. So we've always had a great interest in elimination of viral hepatitis overall, but obviously the release of the Biden, of the Francis Collins HCV elimination plan has really injected a lot of energy into the work that we're doing. And really at the request of Francis Collins and his team, they asked ASLD to help kind of develop a coalition around kind of next steps should such a plan move forward. And many of you participate in the calls that we're having where we're trying to sort of build a coalition and start to be actualizing some of the next steps towards getting, first of all, a bill written and then starting to lobby to get funding for it. You know that it's a big ticket item. It's been estimated to cost around 8.4 billion, I think is the number. But it's a very comprehensive program that the Francis Collins has put forward, which includes diagnostics, building infrastructure and supporting infrastructure in terms of doing a test and treat model, as well as for provision of money for the drugs. It would be obviously very impactful in a state such as California, as it will be nationally. So just to give you kind of a very brief update on kind of where we are. On our last call, we were discussing kind of getting the bill written. That's really kind of the first challenge we have. Right now, it's just been proposed, but we need legislative language that we can potentially have money attached to it. We have been lobbying with various senators, and thus far we thought we had some good traction and had somebody who would be willing to write the bill, but that has not worked out as yet. So we are now expanding our efforts towards other representatives in Congress, maybe more of a grassroots kind of representative upward kind of approach, but we really need that first, because we need something that we can kind of get behind to then lobby at a much bigger level within Congress to get support for it. It's kind of a difficult maybe time to be putting forward such a large kind of ticket item, but we all feel very motivated to get the language, get a bill, get some legislative language, and then kind of lobby behind it. So that's what ASLD has been focused on primarily. But the other thing that we've been doing is really working with our HBV partners, because initially the HBV community of advocates felt that Hep B had been somewhat left behind in this discussion around HCV elimination. So we've been having conversations with Francis Collins' team, as well as our HBV partners. And I'm very happy to say that there's now been some adjustments made to the plan to make sure that HBV is included from the point of view of thinking about screening, as well as, of course, always using the opportunity for vaccination, as well as kind of using the building of infrastructure to support elimination of both hepatitis B and C. So kind of being more thoughtful around that. So I think the Hep B community has really rallied behind this, and it's important because they're an important constituent in terms of getting viral hepatitis elimination here in the United States. We will continue to have regular meetings with coalition partners because I think we still have to be prepared that, this is maybe a long haul, that we may not get it immediately, and that we have to have a plan towards, if we're not successful in getting a legislative, getting a bill put forward at this point in time, that, we keep coming back to the table until we're successful. But just to say that ASLD is very anxious to kind of provide leadership just to allow all the partners to do what they do best. And we have a lot of expertise in the coalition who've done a lot of work previously in terms of advocacy, in terms of bringing forward legislation. So we're really happy to be having that expertise as part of the coalition and working with us. So that's just a brief update. And really anybody here who wants to be involved, we are eager to have you. So please let me know and I'd be happy to loop you into ongoing activities. Thanks.
Excellent. Thank you so much, Dr. Terrault. And sometimes it does take a few years. We're working on a federal bill for cancer, and I think it's the third year it's been introduced. So we just have to keep at it. Well, I think this has been, I've been reading some of the chats and email texts me, kind of enlightening because we're all in this together, but it's nice to get out of our bubbles and to see what other people are doing across the state and then the country too. So thank you for being part of today. Thank you for allowing us to go a little bit over, and let's just keep talking and sharing the news. The engagement opportunities is engage. I won't go into our presentation, but each of us should have opportunities on our website. We have our standing committees are listed and when they meet and how to engage. And we're always going to be looking for ways in which we can fold in people. I know different ministries do the same thing. So with that, thank you and have a great day. And we'll post this on our YouTube channel too. Thank you. It's been,
Well, you should have presentations.
yeah.
Yes.
Yeah, well,